Thank you very much. Thank you for giving me the opportunity to discuss my work with you. My name is Charles Roquetaillade. I am an intensivist and a PhD student in Alexandre Baza's lab. And today we'll talk about cytokines in various infectious aggression. So, as you certainly know, several studies have reported elevated level of cytokines in various infectious diseases, from COVID to sepsis through influenza and other viruses. Nevertheless, there is no clear pattern identified for each disease, since they were never compared between each other. The report of the correlation between elevated cytokines and severity is inconsistently found by studies and inconsistently reported. And when authors found elevated cytokine level, they feel free to call it cytokine storms, since there is no clear definition of it. But this has therapeutic implications, since it commends the use for anti-cytokine therapy. So far, the anti-cytokine therapy was mainly tried in COVID and a few times in sepsis, with quite disappointing results. And the comparison between diseases is required and was only assessed one time in a study published in Lancet Respiratory Medicine in 2019. But this study has several limitations, since it was not a proper meta-analysis and not a complete literature review. It included preprints, and it analyzed syndromes rather than pathogens, which may be misleading. So we sought to analyze the existing literature on the reported cytokine levels in various infectious conditions. We sought to analyze if the cytokine levels can discriminate severe from non-severe forms in those diseases. And at last, we sought to identify if the cytokine pattern can discriminate between diseases. So we conducted a meta-analysis based on literature review. We searched for PubMed, Medline, and AIM-based databases. We included, as I told you, various infectious diseases from COVID-19, but also bacterial sepsis, influenza, Ebola. And off the record, we also screened for SARS-CoV infection and breakbone fever disease, but none of the identified studies met the quality criteria for final inclusion. We extracted from those research and from those papers the levels of the IL-6, IL-1, IL-10, IL-8, TNF, and interferon gamma, so the six more oftenly dosed cytokines and reported cytokines. And we chose to include studies and articles published from 1990 to April 2021. We chose to restrict to this 30-year period, since the methods for the dosing of the cytokines before this period were quite imprecise and subject to numerous bias. We included observational studies, interventional studies, and case series, and we chose to exclude case reports, preprints, non-English studies. We excluded also the studies for which the mean and standard error of the mean could not be obtained, and we excluded the studies which included less than 20 patients. So based on this algorithm of cytokine and of those cytokines on those diseases, we found 9,231 studies which could be screened for eligibility. Among them, only 241 were finally assessed by full reading of the manuscript. For the above-mentioned reason, we excluded 151 articles, so we finally retained 90 studies for our analysis, which accounted for something like between 15 and 16,000 patients. So for the reported cytokines, let's start with IL-6, which is the more oftenly reported cytokine. So we clearly demonstrate here that sepsis is the main IL-6 driven disease. This is a logarithmic scale, so as you can see, even severe sepsis exert a higher level of cytokine of IL-6 than COVID, with an association between severity. The most severe cases tended to exert higher level of IL-6. Influenza and Ebola had lower levels for the cytokine. We found quite the same pattern for IL-8, which is a similar, very inflammatory cytokine. Sepsis was the major disease with the higher level of IL-8. And we found a clear correlation between higher levels and higher severity for COVID, but also for sepsis. IL-10 was found quite elevated in sepsis as well, but this was previously reported, and the association with severity was found together. Interestingly, we found that Ebola patient suffering from Ebola exerted very high level of IL-10, which was not described in the literature before, which certainly deserves further investigation. As you can see, there is quite a few patients, only 75, so this may be a bias also, which should deserve further investigation. There is no clear association between disease and TNF levels, so difficult to exert conclusion on this, but we can see that patients with influenza had the higher level of TNF, and this may have implication on the ability to patient to clear the virus. And the interferon, very interestingly, the interferon gamma level was much lower in critical COVID compared to the severe ones, which may have something to see with the aberrant macrophage activation that we see in the critical case of COVID. And we'll discuss this later, but this may have something to see with the incapacity of macrophage to clear the virus in the lung. And at last, the IL-1 beta reported levels were inconclusive and very scarce. So the main findings is we need more data on IL-1 beta levels. So to conclude, we can say that COVID-19 inflammation is far inferior to sepsis inflammation. So sepsis could say, who's the cytokine storm now? Because I think this is the leading infectious cause of cytokine storm. But this study is also hypothesis generating. We found that influenza was associated with high level of TNF. This is consistent with preclinical studies and fundamental studies. We found that TNF was very important for lung epithelia to clear the virus. So one can hypothesize that patients who are not able to synthesize TNF may have higher burden of pathogen. We found that low interferon gamma was associated with critical COVID compared to severe COVID. This is consistent with aberrant macrophage activation. This was reported in several reports previously, and several authors have found that people with the lower level of interferon gamma are the most at risk for subsequent development of lung fibrosis. And we also found very high levels of IL-10 in Ebola, which may deserve more investigation. Of course, our study suffers several limitations. The studies were very heterogeneous. The method of measurements were not always the same. And the weighting of the studies is also subject to discussion. But the main thing here is the perspectives opened by the study. And I think that cytokine measurements should, we have the element to say that cytokine measurements should be implemented in routine clinical use. It can serve as a risk stratification. And Adria Pico recently demonstrated that among all patients admitted in intensive care, whatever the motive of admission from infectious cause, but also cardiac failure, the level of IL-6 measured on admission was linearly correlated with 3 months mortality. So and this was superior to other biomarkers such as PCT, CRP, and even the severity scores. And maybe in the future, immune monitoring and assessment of cytokines level may lead to tailored immune therapy, but this is maybe in several years. And at last, since we clearly see, and we are not the only one to see that sepsis is the leading IL-6 driven disease, maybe it's time to try anti-IL-6 receptor therapy in the setting of sepsis. I thank you for your attention.
Okay, anybody have questions? While they're thinking, I've got one for you. I've done a few meta-analyses, and when you put your first search terms in and it comes back 9,000, what did you do?
We screened every one. No, we extracted it on a CSV file, and then we screened every title first. And when the title was imprecise, we read the abstract. And we did it for the 10,000 studies. I was not alone.
I would have thought it takes 3 years. All right, anybody with questions? Did you submit this for publication somewhere?
Not yet,
Okay.
but I'm looking for maybe a senior statistician to read again my work, because I'm not a senior statistician, but
Perfect.
if someone is interested.
Luella's volunteering right there. Do you have a question? She has a question.
Microphone, please. Grazie mille.
Prego, prego.
So, of course, this begs the question of why steroids doesn't work for sepsis when it works so well for COVID.
I'm not sure I understand, but you
So you've presented data which shows that the cytokines levels are higher in sepsis than in COVID,
Yes.
and we know that dexamethasone worked extraordinarily well for COVID. Is there any hint in the data that you've seen as to why steroids don't work so well in sepsis as they do in COVID?
So you assume that steroids doesn't work in sepsis? Yes. Well, I'm not sure everybody agrees on that, but okay. But I mean, dexamethasone is very wide range anti-inflammatory drug, so there's nothing comparable with anti-cytokine therapy. I'm not sure I understand well your question. I'm sorry, but dexamethasone is not immune therapy. I mean, it's wide range therapy, but it exerts mainly cardiovascular effects, at least in sepsis. So I agree with you, it doesn't work for its anti-inflammatory properties. And the reason why it works in COVID is I'm not sure we clearly understand well why, but maybe it has something to see with the aberrant macrophage activation, because the pathophysiology of COVID in the lung is very similar to macrophage activation syndrome in the tissue. I mean, so this is not the same pathophysiology than sepsis. Maybe it's the reason why.
All righty. Thank you.